Hello everyone. Today we will discuss ovarian adnexal reporting data system created by American College of Radiology. I request you to watch the previous video on ovarian cystic lesion USG approach before watching this video. This is made in revised in 2022 and it is made by American College of Radiology with gynecology and radiology departments. Online article is there, you can read that. This is the orads 1 category in which there is normal ovary or two functional cysts which are around 3 centimeter size and they are follicle and corpus luteal cyst. Follicle it will be less than 3 centimeter or 3 centimeter and it will be simple cyst and this is a corpus luteal cyst which is around 3 centimeter but it can show thick wall and peripheral increase the vascularity. Sometimes it can be solid but on color Doppler it will show peripheral vascularity. In ORADS 1 category, there is no need to do any further follow-up. Then ORADS 2 category, in that we have simple cyst, but it will be more than 3 centimeter and less than 10 centimeter. And 3 non-simple cysts less than 10 centimeter. Non-simple in this first will be with echoes, second will show incomplete septum or it can be bilocular. Then ORADs 2 also contain typical benign ovarian lesions less than 10 centimeter and they are endometrioma, hemorrhagic cyst and dermoid cyst. And also they will include extra ovarian benign typical cystic lesions like hydrosalpinx, para ovarian, extra ovarian simple cyst and peritoneal inclusion cyst. We will see how to follow up these 1, 2, 3, 4 cystic lesions in this slide. This is a premenopausal column and this is a postmenopausal column. In this simple cyst, we will see how to follow. If the simple cyst is less than 3 centimeter, as we know, in premenopausal there is no need of follow because it is follicle, and in postmenopausal also there is no need to do any follow. If the simple cyst is between 3 to 5 centimeter in premenopausal, we don't do anything, but in postmenopausal we will do 12-month follow. And if the simple cyst is between 5 to 10 centimeter, we will do 12-month follow-up in a premenopausal or also in a postmenopausal. If the cysts are not simple, non-simple, like these three, echoes, incomplete septum or bilocular, then how to follow? If they are less than 3 centimeter, we will do nothing in a premenopausal group, but we will do 12-month follow-up in a postmenopausal group. And if they are between 3 to 10 centimeter, we will do 6-month follow-up in both pre and postmenopausal patients. For typical benign ovarian cystic lesions like hemorrhagic cyst, dermoid cyst, and endometrioma, how to do follow? In hemorrhagic cyst less than 5 centimeter, we will not do any follow-up. If it is between 5 to 10 centimeter, we will do 2-month follow-up. And if the cyst is more than 10 centimeter, hemorrhagic cyst, which is very rare, we have to do MRI for further characterization and confirmation of its benign nature, and then we can do 6-month USG follow. For dermoid cyst, if it is not surgically removed for symptomatic reason, patient anxiety or risk of torsion, Then we can do 12-month follow-up with USG. If there is any doubt on ultrasound and if it is not showing any typical features on ultrasound, we can do CT or MRI for detecting fat, which is diagnostic of dermoid cyst, and both CT and MRI are equally sensitive. In endometrioma, how to do follow-up? In premenopausal patients, if the endometrioma is less than 10 centimeter and if it is not removed surgically, we can do 12-month USG follow-up. But if it is more than 10 centimeter, we have to do MRI for confirmation. And in postmenopausal, if the lesion is less than 10 centimeter or more than 10 centimeter, we have to confirm it by MRI. And if it is not suspicious, then we can do 12-month imaging follow-up. This is a hemorrhagic cyst. Typical, it is showing fishnet appearance, reticular pattern, thin septa are there inside. This is a dermoid cyst showing acoustic shadowing. This is the echogenic focus showing shadowing here, and cystic component is showing echogenic lines or dots. Endometrioma showing homogeneous low-level ground glass internal echoes. Then coming to the orads 2 last category, these are extra ovarian simple cyst, peritoneal inclusion cyst, and hydrosalpinx. In these cases, there is no need to do any follow-up. Gynecologist will treat it accordingly. Then on left side there is orads 2 category, which we have already discussed, and this is the orads 3 category, which we will discuss now. What are the cystic lesions or lesions which will come under orads 3 category? We will see one by one. First is unilocular simple cyst, but it is more than 10 centimeter. In orads 2 it was less than 10 centimeter. In orads 3 it is more than 10 centimeter. And if it is showing focal wall thickening, but it has to be less than 3 mm. If it is more than 3 mm, it is called papillary projections and it will go in orads 4 category. Then multilocularity will come in orads 3, but again the cystic lesion is less than 10 centimeter, and on color Doppler there is not that much vascularity. Color score is less than 4. What is color score? 1 is no vascularity on color Doppler, 2 is minimal vascularity on color Doppler, 3 is moderate vascularity, and 4 is very strong vascularity. Then these two lesions are solid lesions. Both are showing smooth border, no lobulated outline. The last one is showing shadowing. The first one may or may not show shadowing, but color score should be 1. Means on color Doppler there should not be vascularity. But if it is showing shadowing and if it is showing not intense vascularity, very strong vascularity, we can categorize it into orads 3. And what orads say that if they are not surgically removed, for these three types of lesions we can do 6-month USG follow-up, and for these two solid lesions we have to do MRI. Then we will see orads for category. On left side there is orads 3 for comparison. We will see what are the cystic lesions which are kept in orads 4 one by one. The first lesion is showing irregular septi. Second is showing smooth contour locules, but it is showing vascularity, but it is showing more than 10 centimeter size. In orads 3, The size was less than 10 centimeter for this type of multilocular lesion. Then the third is, it is showing intense vascularity, multilocular cystic lesion. Septa are showing intense vascularity. So size doesn't matter here. Then this is the lesion which is showing less than 4 papillary projections. Then this is a unilocular, but it is having solid component. This is multilocular, showing solid component, but color score is 1 to 2. This is solid lesion, not showing shadowing, but it is showing smooth border and color score 2 to 3, not 4. If it is showing 4 color, then it will go into the 5 category. And if it is showing shadowing, it will go into the 3 category. What orads say, we have to do MRI for all these lesions, and gyneco-oncologist will decide the further management. Remember, in orads 10, the risk of malignancy is between 10 to 50%. Then coming to the last orads 5 category, they will have more than 50% risk of malignancy. In this first is cystic lesion showing more than 4 papillary projections. Then the second is multilocular with solid component with high color score, means high intense vascularity on color Doppler. Then solid lesion, smooth border, but color score is very high, 4. In this color score was less. Then it is showing lobulated outline, solid but lobulated outline. Then this irregular outer contour will keep this lesion in orads 5 category. Then peritoneal fluid, peritoneal deposits will keep the lesion in a orads 5 category. So imaging wise, gyneco-oncologist will decide to go with CT or PET CT for staging directly instead of MRI, because most of the time they will be malignant. So to conclude, orads say that we should try to use orads staging to have a uniform pattern of reporting, and it will guide the further management. And we should take into account the size of the cyst, then the morphological features like safety, locularity, solid component, papillary projections, vascularity ranging from none to high vascularity, then papillary projections. Then in case of solid lesions, we have to consider shadowing and vascularity and irregular outer contour. So we should try to use it. It may feel very difficult initially, but we can keep the print in sonography room in file, and we can try to use it. Thank you very much for patient listening.